So, what is integrated healthcare? Here is your World Health Organization description. And boy, is this thorough, and is this a lot of words. It even has the word continuum in it, which might be the only word that has two U's next to it. So this is very fancy and very bureaucratic. And I get it, it works. Kind of covers everything. The management and delivery of health services so that clients receive a continuum, preventative, and curative service according to their needs over time across different levels of the health system. Period. I also found this one. I kind of like this one. This was for somebody called this, an organization, called the Center of Integrated Healthcare Solutions. I like the first sentence here, the systematic coordination. Because it has to be systematic. We can't just say, oh yeah, we're kind of talking to each other. Oh yeah, we know what's going on. A lot of the reporting that Diane was able to pull together and talk, it's systematic. It can't be willy-nilly. It has to work. Now my favorite representation of integrated healthcare is the genius Venn diagram. Everything overlaps and talks. Notice, let's say B is patients. Everything overlaps over the patients, but notice A and C also overlap, and C and D overlap. It's your classic Venn diagram that I'm not sure who invented it. Maybe a guy named Venn, probably. But I think that's the best representation of how an integrated healthcare system works seamlessly. So the question also becomes who is in those circles? And I see we have one over here that's kind of a Venn diagram, I guess, in a way, if these are all overlapping, which I say that they probably are. And I have a list up there of who's in those circles, and this is by far not an inclusive list. I put this slide there last night at about 11:30 p.m. And if I were to put everybody on it, I would have been up to 12:30. And I need to get some sleep, because I do have a 2-year-old and I have one that's going to be here in 2 months, so I won't be sleeping much, getting what I can now. So as you can see, we have pharmacists, school nurses, public health officials, rehab therapy. That happens a lot in traditional integrated care models. That's physical therapy, occupational therapy, getting people back on their feet. Alternative medicine's become a big thing in a lot of integrated healthcare systems. Acupuncture, chiropractor. A lot of people are starting to recognize that there's a place for those in the integrated healthcare world. Even third-party payers, insurance companies. But there's a lot here that I didn't put, because then our Venn diagram gets huge. But that's the important thing you have to remember, is that it's everybody. It goes to parents, it goes to community workers, it goes to people in law, people in public policy, all of that. So these are the slides that I did not need to do, but I'm going to do them anyway, which is, how does asthma and integrated care work? This number kind of floored me, that every single day, 36,000 children miss school due to asthma. And as Diane pointed out wonderfully, the ramifications of that are huge. That's where asthma and integrated care come together, because the kid is in so many different places. The physician's office, the pulmonologist, the school, the home, the pharmacy. And as Diane said, what asthma is the most common chronic disease contributing to absenteeism. It's more common in low-income families. And in a report in the Journal of School Health, this quote I like, that it's an educationally relevant health disparity. That there are different health disparities, and this one actually affects education more than anything else. So these are all the whys. Now let's talk about what it is. This Rite Aid GPPA integrated health system that we are building more and more every day. This actually was birthed here last year. Somebody from GPPA met with Danella and said, let's get together and talk about how this is going to work. The biggest thing that they thought was this. One of their patients comes into their facility for their usual visit. They go through, this is your controller medicine, this is your rescue medicine, so on and so forth. Let's make an appointment in 6 months, and they tell them all the important things. In that 6 months, the patient has exacerbations and goes to the hospital. Well, they see a different doctor at the hospital than they see at GPPA, but they have to get their prescription filled somewhere. So they come into the pharmacy to get their prescription filled. GPPA doesn't even know that their patient is out of control, had to go to the hospital. So that was with the very beginnings. Can you help us monitor how patients are using their medicine? Also, the notion of how often you have to use your rescue medicine. As Diane said, the schools only know so much because they need the parents to tell them how much they're using it at home. As a pharmacist, when you run out, I know because you need it again. And I can see how often you're using it. And I can have a frank conversation with you. I see you, and I know you, I know your kids' names, I know what car you drive, I know everything about you. So I see you all the time, it's easier to talk to you, I'm much more friendly. I also can talk to you about your controller medicines, how often you take, I can monitor it. That's where all of this started from. So these are just some of the advantages of what we're putting together. The easier patient access, if they have a question, they can just come in and talk to us. The bottom one here is my favorite, happier kids and parents. I'll say on a personal note, when someone comes into my pharmacy and I tell them that, and they have a child that's an asthmatic, and I tell them I'm a certified asthma educator, they listen to that more than they listen to anything else I tell them. People stop being in a hurry when I tell them that. They want to hear what I have to say. They're happier, they feel more comfortable. It's the education piece that people want. And you have to get it from a lot of different spots. So that's what we're going for. Happier kids, happier parents. What it looks like now is there are, I think, 5 GPPA facilities that we're ramping this up in. We have 13 pharmacists that we've gotten certified in asthma education at 10 different pharmacies, located all throughout Metro Atlanta, from Athens to Newnan. That's where we are right now. We're still always trying to add more pharmacists to get their asthma education. So what does this look like as a model? And I'll look at it from the patient's point of view, the pharmacy's point of view, and the physician's office point of view. For the patient, we want it to be as simple as possible. One of the things that GPPA suggested was, let's give them an asthma card. If they're high risk, it's red. If not, now, hearing Diane say that, maybe going with the high risk and all that maybe isn't necessary. We'll help them learn how to use their inhalers better. We'll show them those diagrams of the airways. They see those diagrams all the time. Let them see it some more. That's what we're after. So it's really, also the last one, the financial aid. That's a big issue because we have a lot of physicians. They got a lot to worry about. They try to think about how insurance affects it and all of that, but we can help. We can help make sure that somebody's not taking their controller medicine because they can't afford it. There's a lot of different avenues we can go on there. So for the patient, very simple. Here's the prescription, there's no enrolling, there's nothing else. It's seamless. At the pharmacy, I've already talked about a lot of these. What are we going to do? Talk about show them how to use their inhaler. 2/3 of asthmatics use their inhaler incorrectly after 3 months. 2/3. That's probably why my wife needed 15 of them. She couldn't use them correctly. You have to reinforce that stuff. I also talked about the monitoring of the rescue refills so we can gauge their controller. Talking about trigger avoidance. What are triggers? That's where you can have the conversation. Remind them to change their air filter. Tell them what kind of air filter they need. Tell them where their air filter is in their house. Or if they're in an apartment, we can help them. Hook them up with people like Richard who can talk to there goes the integrated care part. Who can talk to their landlords about issues. We also have immunizations. We do immunizations at the pharmacy so we can make sure these kids who are high risk for flu get their flu shots. Some more of what we did, the asthma control test, another great one I love the asthma control test because it gives the patient a number. They take a 5-question quiz and it says you're a 23. And then they start taking their controller medicine. They take the quiz 2 months later. Now they're a 22. 2 more months, now they're 19. They can see the improvement. Because if you're diagnosed with high blood pressure, you take your medication, you go back, your numbers drop. Numbers are good, they let you know how you're doing. So we love to do the asthma control test as much as we can. We'll of course direct them to other resources, websites, stuff with their schools, all of that kind of stuff. So the pharmacy is more about the consistency of seeing them all the time. I'll see people down the aisle get toothpaste. They're not there to even get their prescription. And I'll run over and ostensibly go out to help them pick which flavor of Colgate. But ask them, hey, I haven't gotten your controller in a while, how's it working? Get them to talk, because a lot of times they'll tell you things just by talking to them that they don't tell their doctors or others because they're intimidated. So what it looks like, so that's how it is at the pharmacy, what it looks like at the physician's office. They get, one of the big things that's happening these days is improved adherence, which means taking your medications, because medical facilities, especially physicians, are going to be judged more and more on if the things that the treatments, interventions that they've used, whether they actually are doing anything. You can't tell if anything's doing anything if someone's not doing it. So we can help with that. When we talked to GPPA, and I mentioned this second one, streamlined third-party resolution, I had about 4 or 5 nurses almost pass out on me. Because so much of their day now is built on calling insurance companies and all of that. You help to remove some of that from them, increase patient care for those nurses when the patients are in the office. And the administrative reduction also was quite a hit. More of what it looks like, this is kind of how the communication goes. What I talked about is systematic, coordinated communication. We would call, certainly if there was a specific patient that's having an issue, but let's talk about it before we get to that point. So every week, every month, we would call, go over all of the patients, how things are going, so they can spot issues. Integrated care is about different sets of eyes that have different skill sets, seeing all the same data so they can see it differently. And then we'll do like quarterly rounds, and GPPA can kind of be built as a regional leader in integrated care. So I hope you're getting that this is designed to be really simple, not designed to be exotic or anything like that. All we do is talk to folks, mark down what we're doing, and share it with others. Very, very simple. So what comes next? Well, right now we're already enrolling patients completely informally. Nobody has to fill out any paperwork. Nobody has to give me their credit card or their maiden name or their street they grew up on. We just talk to them. We have a sheet of paper that we write down when we talk to them and what we talk to them about. That serves 2 purposes. Gives us the data that we can then go back and look at, and lets us know when was the last time I talked to them about their controller medication? When was the last time I talked to them about triggers? Those kinds of things are in there. Also, that serves as a vehicle, like Mr. Passons was saying, of having guidelines for our pharmacists to remember the black box warnings in places. Also builds up the relationship between us and the physician, so that it's not confrontational, it's collaborative. As we get going, we'll be doing more and more of the identification of those high-risk kids, the referral flow back and forth. If we find someone who is, maybe their primary care is kind of missing, we can refer them to these specialists. And then we just collect the data and publish the results and see what we can improve on, what gets better. And then after that, we have bringing all the other ones together. If right now, what we're building with these 2 partnerships is a 3-circle Venn diagram, we'd like it to be 50. And you bring in schools and daycares. A lot of our certified asthma educators can go into daycares and give talks to education to the caregivers, same thing with schools, all that kind of stuff can keep expanding as we get deeper and deeper into it. And then finally, there's a spokesman who happens to look remarkably like me, minus the suspenders. This is Aaron Lungs. If none of you have seen him before, he's kind of the caricature behind our website. The idea here of him being Smokey the Bear, in a way. of an identifiable guy. So this website's very simple, aaronlugs.org or aaronlugs.com, bringing you to the same place. That's all the educational tools and their school stuff on there and all that. So that in a gist, my presentation's short because a lot of the integrated care stuff is already there. It's making that one little systematic connection, coordination, and growing it so the patient always feels at home with whoever they're talking to. Almost every patient I talk to, they just think that an asthmatic is going to go through life breathing through a straw, pinching their nose, and jumping up and down. And it does not have to work like that. And hopefully this model will grow and get better and adjust, and with everyone's help it will. Thanks everyone, and I need to clean the snot off the back of my pants.
Hi, good afternoon. I'm Christy Curiatne, and I have with me Francesca Lopez. We are both from the Department of Public Health, the Georgia Department of Public Health, and I'll let Francesca talk for a minute about her program. I'm with the Healthy Homes program, which is in the environmental health section of the Department of Public Health. And so what we do in my program basically is we look for children who have lead poisoning. We maintain them, we do surveillance and collect data on children that have lead poisoning. And then the other flip side of what we do is also the Healthy Homes component, where we look at issues like indoor air quality, and we provide guidance and support to the public, and also to some of our targeted audiences as well. We also lead the Georgia Healthy Homes Coalition. So I would like to invite anyone here who would like to be part of our coalition. Back on our table at the back of the room, we have a sign-in sheet. If you want more information, we can send that out to you. We have quarterly meetings. Our next meeting is June 11th. So I would be pleased to have anyone who's interested in joining our coalition, to attend and be part of it. So I'm going to turn this over to Francesca.
Thank you. We tag team. We work together well in the state. I wanted to call you all's attention to this program summary. It's on the back table. Please do, if you have an opportunity, to pick up one of these. It talks about what we're doing at the state level to address asthma. There is a 2013-2018 strategic plan to address asthma in Georgia. It has 4 major components. So one is caregiver support. So we're looking at innovative ways to provide self-management education to caregivers and children with asthma, as our focus population is 0 to 17. We are also looking at our payer groups. How do we, in a comprehensive way, reimburse and incentivize caregivers to practice based on evidence-based practices? And lastly, we are looking at our schools and our child care settings. We have launched the Georgia's Asthma-Friendly School Policies. We love Diane. I've been a student, I'll say, of hers for quite some time. They're doing innovative work there in Texas, so we hope to see her again quite a lot here in Georgia to help us move forward our policies. Again, our role in the state is to really focus on those policies and systems that we can leverage on a state level. Some of you may have heard that we just got, through this last legislative session, a new law passed, SB 126. It now authorizes schools to stock albuterol and administer albuterol in the event of an asthma exacerbation or respiratory distress among a child. This child does not have to have a prior diagnosis of asthma. As we know, many children go without that diagnosis for quite some time. So this allows our school nurses and our health givers in the school setting to save a life there and not have to be constrained with, is there a prescription, or did the child get their prescription at home and so therefore I can't give them albuterol. And another piece of this bill also expands the authorization to access epinephrine. So there had been a bill in place for schools to stock epinephrine. This bill extends that authorization to other settings, such as restaurants, YMCAs, that will be designated by the Department of Public Health. So on a state level, we're putting in systems and policy changes that will impact what we do on a local level. Thank you, and thank you for